I get the really distinct pleasure of introducing our first presenter, our plenary speaker, Dr. Rohan Radhakrishna. Dr. Radhakrishna is a public health practitioner, a family physician, and a public servant with over 20 years of experience learning from and working with impacted communities across the globe, having spent time in over 40 countries. He was appointed by Governor Gavin Newsom in 2021 to lead the Office of Health Equity and serve as Deputy Director and Tribal Liaison for the California Department of Public Health. He is a graduate of 2 UCs and really excited to be with us today. Thank you, Rohan.
Good morning, students, faculty, fellows, researchers, healers, professors in the room and across the globe. My name is Rohan, and I stand for love, for dignity, and for transformation. Love and dignity for all beings across this planet, and transformation of our systems and institutions that have caused harm and that can bring health in powerful and meaningful ways. I'm so grateful to be with you as an alumni of UCs, having participated in many global health initiatives through the UCs and outside of the UCs, to bring us together as change agents, to unite. I'm going to spend the next hour talking about how you all can leverage your skills and power for transformation through policy and advocacy. So let's get started. How many of you have played the game Monopoly before? Raise your hand. All right, I figured to be a bunch of anti-capital colonialists never played the game, but looks like some of you have. So, I got a couple kids, we played the game, and if you think about playing a game of Monopoly for a couple hours, say 4 or 5 hours, it's pretty different if you're at the game from the beginning, or if you're only invited to the party an hour later or 2 hours in. Some people, some communities, invited at the 3rd and at the 4th hour of the game. And by then, properties have been taken up, resources have been given away, connections have been made. And we're talking about minorities across the globe, not for hours, but for centuries, who have been excluded and not at the table for resources and power, for the key determinants of health. We're talking about women. We're talking about racial and ethnic minorities and sexual minorities, which you'll hear about from Frank at the end of today. And so it's not a level playing field, and it hasn't been an equal game due to the impacts of colonialism and globalization over centuries in this country and in many countries due to policy. If you think of compound interest and the loss of not being at the table early on, the multi-generational loss and trauma, it impacts the body. So we can't talk about the body without talking about politics and policy. And we gotta level the playing field by pulling on those levers and structures and getting into those gears. So it is possible. There are frameworks, including from healthcare providers like this one, that talks about having precise impact on the communities where the disparities are the greatest. By changing not just bodies and people and organ systems and families and communities, but actually the policy systems and environments that created the disproportionate harm over time. And we don't want short-term change, we want long-term transformation to undo the harm over centuries. We need to apologize, and when necessary, we need to offer reparations in concrete form. So before we talk more about history and frameworks, let's talk about some of the successes on the global health stage. Thanks to policy, here you see the 6 regions of the World Health Organization. And on the left, you can see in red in the Americas, starting out with the Caribbean, that there were actually decriminalization of consensual same-sex relations as a major progress in global health. And in Brazil, you had the upholding of indigenous land rights, which is so important to self-determination and controlling one's culture and land, key to health. Many nations being declared malaria-free over the past year. And if we focus on Africa for a moment, in purple, we can see advanced tobacco control policies in Mauritius and Egypt getting advanced tier gold status for hepatitis C elimination, as well as countries like Benin, Mali, and Iraq moving towards eradicate trachoma and eliminate the leading cause of blindness. So a lot of progress to be proud of. If we look over to Asia, we can see, let's just take Bangladesh for an example, a country that in 1 year eliminated record-breaking 2 neglected tropical diseases. Pop quiz, does anybody know what those 2 diseases are? Visceral leishmaniasis and lymphatic filariasis, also known as elephantiasis. Say that 5 times fast. So we've seen progress on the global health front, but we also have tremendous challenges, and we're going to break into all of them in this next hour and all day long. We asked you to vote. What are the major global health challenges? And you told us healthcare access, the impacts of the climate health crisis, strengthening healthcare systems, poverty and food security, displacement and migration, which Madhavi mentioned, mental health and gender equity. Well, let me just talk about number 5 for a moment since Madhavi opened it up. And I'm grateful that out of the 230,000 faculty that are part of UC, we have Ndola Pratap, my Master of Public Health at Berkeley thesis advisor in the house, a demographer and doctor from Angola who schooled me on demography when I was a grad student sitting in many of your shoes over 15 years ago. And my thesis project as a public health graduate student in the UCs was the impact of displacement, in this case on the Uganda-Sudan border after a 20-year civil war. But it's not just economics and forced conflict, it will also be the climate crisis that drives the migration of species and vectors and humans that lead to pandemics sooner than we're realizing. And just like Madhavi said, we have to tackle head on as health advocates the impacts of displacement, migration, and war. So we're speaking to you from California, and with humility, we have a lot to learn from the global context, and we've borrowed and stolen a lot of great ideas and innovations from the global marketplace. But we also need to realize that California is a global juggernaut. 5th largest economy in the world, most diverse state in the United States with 10.5 million, 27% being foreign-born, like my family and relatives, like many of your families and relatives. A lot of the education and the talent in the UC system coming from abroad. Racial diversity growing in our legislature. In 1990, it was about 13%, and now we have more than 53% people of color identified in the California legislature. In fact, just this week in Sacramento alone, we had a mayor race between a pediatrician, former Senator Richard Pan, and a doctorate of public health, a black woman of color, Flojan Kofer. We need you all engaging in government at the local, state, and global level. But it's you all, the younger Californians, that will shape our future, and that's what gives me hope. So let's talk about how California is a microcosm for global health. Let's go way back to the very first set of UCGHI 10 years ago newsletter, quoting the governor at the time, Governor Schwarzenegger, who said, "The health of people around the globe is the health of California." And you heard that from the chancellor today. And we got a postcard from the future, a dress rehearsal for what it means to be dealing with global health crises here at home with the COVID-19 SARS-CoV-2 pandemic. So, if California is a microcosm, how can we learn and lead from where we are using our power and privilege? We're gonna zoom out a little. You heard President Drake talk about the social determinants of health, and you heard Madhavi talk about the structural determinants of health, but we need to zoom out even further to talk about the political determinants of health. I'm grateful, another one of my thesis advisors at Berkeley said on day one, whether you like it or not, public health is political. So get your head out of the sand and get in the game, because it matters. So we're gonna talk about the political determinants of health, global health trends, and most importantly, skills to translate science to action for impact. We're gonna talk about trust and how we recognize and own our own power to drive policy and advocacy. So this slide is a nice graphic to tell us what we're talking about from a narrative and graphic frame, that it's not about equality or the sameness. If you think about the Monopoly game over centuries, sameness will not drive equity. It can compound inequity. We need beyond equity, which is customized tools for certain people and populations with greater access to resource needs. We really need justice, sometimes to break and rebuild systems, certainly to structurally adjust them towards justice by shifting, like you see the apple tree being moved and buffered and scaffolded. What are the policies that have contributed to health disparities? And no matter what country you're listening from today on the global live stream, look at the history books within your own country and think about what we need to acknowledge, apologize for, and repair, and what are the current policies continuing to drive health disparities? In the modern United States, we have the history of the Indian Removal Act and the Trail of Tears, and California has its own sordid history of its Trail of Tears and denying 18 treaties for indigenous groups to get land back at the time of the Treaty of Guadalupe in the mid-1800s, right around the time the UCs were formed. And in 1907, we had eugenics and the forced sterilization of women of color and low-income women. We had the forced return of people serving in this country and migrants, as well as Muslim travel bans most recently. So is it nature or nurture that determines our health more? Is it the zip code or the genetic code? And we know it's a combination of both, but the power of place and policy is so important that we need to study it more in our health sciences. Here's a rapid transit map from the Bay Area where I live, and if you see the city of Walnut Creek where my father lives, the average life expectancy is 84. Greater education, greater income, lower pediatric hospitalization rates for asthma. But a couple zip codes next to where I live in Oakland, in communities that are positioned historically due to redlining, with poor housing stock, closer to factories and the port and highways, you have a much higher rate of pediatric asthma hospitalization and a much lower life expectancy. 20 minutes on a train ride and you can lose 11 years of your life expectancy. Same in Richmond, where I served as a family doctor for 10 years. So what is the point of treating people only to send them back to the conditions that make them ill? Sir Michael Marmot, when I watched him speak on the topic, cried, and we should be, with what's happening and the lack of change in the conditions, growing disparities for many conditions across the globe. So it's important to cry and release and support each other and to take on the conditions. Let's go back old school to the mid-1800s to Rudy Virchow, the father of pathology, and remind us that medicine is a social science, and health professionals are the natural attorneys of the poor. And many times people say, health, stay in your lane. You shouldn't get involved in the social stuff and housing and poverty and policy and politics. No. We must and we should. So do your research no matter what country you're in. Look at your government code of regulations and find what can defend us taking on the lanes that matter. Because 2/3 of health isn't what happens in the body or the clinic. It's the social, environmental, and behavioral health factors. So I frequently cite to those who say, Rohan, stay in your lane. Well, the California Code of Regulations say that the health department shall offer services directed to the social factors affecting health. Check it out, Title 17, Section 1276. So these frameworks matter, and I'm grateful to the Bay Area Regional Health Inequities Initiative, BARHI, for this framework that really helps us know, yes, we have to do the downstream and help organs and people and body systems, but we need to shift more of our time and resources and learning towards the midstream and upstream, what's in the purple diagram, of those conditions that determine health, as well as the institutional and societal inequities. Here's a great slide from a colleague of mine who just published this article a couple weeks ago. Keeping It Political and Powerful is the title of the article in the Milbank Quarterly. And this is those structural determinants of health. Let's talk about housing for a moment, a crisis that we're having in our state and in many places around the globe. And while it's great to offer a medicine, a widget, a therapeutic, a vaccine, housing, providing shelter and services, no matter the context, that's at the lower level of what we can do to drive the structural determinants of health and increase the distribution of power and decision-making. As health professionals and providers and students, we need to go further upstream and talk about budgets, zoning, housing development, change laws about land ownership, implement practices to prevent segregation, displacement, and gentrification, build coalitions, and ultimately change narratives and beliefs about the history of segregation and what it means to have the commodity of housing. So, going upstream, we have to tackle the political determinants of health. And Dina, who I met last night's here, she likes the blue and gold, so our goal is to get to the gold in the top right, which is equity. But the only way to get there is to get into the system and change it. And that means those green boxes of voting, important year for that, important week for that, advocacy and policy is essential. I tell people I took a job in state government to really be an anthropologist in a sausage factory and figure out how the sausage is made. And You got to get in there and understand the gears and the levers of politics and of policy to drive the upstream change, to address the multiple levels of discrimination that we experience and our patients experience: structural, institutional, interpersonal, and intrapersonal. So I'm so honored to serve in this administration whose tagline, as you see in the top left, is a California for all. It's really an equity agenda, and it's what called me to serve this state. And the first Office of Equity in state government was the Office of Health Equity in the Department of Public Health, formed 11 years ago. So I'm so honored for the past 3 years to be leading in this role. And here are the priorities under my watch: advancing racial and social equity in government. Government has big P policies, big budgets with a lot of zeros, and can really drive and support locals, partnerships with academic and community groups, and philanthropy, but we must always do it through a racial equity lens. Behavioral health. It was Surgeon General Admiral Vivek Murthy who came to Los Angeles 2 years ago to declare the youth mental health crisis, and so we're leaning into that space as well. That's a global phenomenon. First, the WHO reported on the mental health harms of adolescent girls globally, then the CDC, and now our administration's focusing on it with the Child and Youth Behavioral Health Initiative. The greatest planetary threat of our century is no doubt the climate crisis, and so our team is leaning into that, using data and embedding health and equity into all of California's global leading policies around climate, and really aiming for an equitable COVID recovery through partnerships and health in all policies. And finally, housing and homelessness, perhaps the greatest of the social determinants of health that easily can take up to 25 years off a person's life expectancy if unsheltered. So we're taking the equity moment from COVID, from the racial justice uprisings, and trying to turn it into an equity movement. And just like every county has a tuberculosis controller and a tobacco staff, we want them to have an equity executive in the room where it happens, where decisions are made for crises and for long-term planning. And I'm proud to say that we now have 47 out of 61 local health jurisdictions in the 58 counties across California that have equity leads and even equity teams to be ready to support current issues and future crises. So for the first time, we convened in Sacramento and brought 200 equity leaders across California embedded in government at the local level to have our convening. And here you can see a graphic recording sharing about what the work we did. I describe this movement building of infrastructure as 21st century health and public health. And my boss, Tomas Aragon, tells us the importance of visualizing it. Our agency equity officer, Dan Torres, talks about building that movement with more momentum. And our community engagement panel told us like it was. It's about recognizing the community expertise, getting a variety of voices in the room, and ultimately driving impact through trust. So, having learned from so many global contexts, here in California, noting many of those populations and communities are here, I'm so proud that your California taxpayer dollars are funding prevention and early intervention through Culture for Health. We're funding 35 community-based organizations, Black, Tribal, Asian Pacific Islander, Latinx, and LGBTQ, to deal with culture as health. And I'll share 2 examples. First, we have in the Central Valley, the breadbasket of California, with the Hmong refugee population, the Fresno Center. They had isolated elders who were suicidal, and I still remember the story of one woman being disconnected from her culture, that root shock when you're removed from your culture due to displacement, whether forced or economic or climate-driven, ending up in the Central Valley. And we're using our dollars, and I was proud to be at the ribbon-cutting ceremony for a community garden where they can grow Southeast Asian vegetables and people can be together, singing, outdoors, enjoying culture and reviving it, returning to the village, no matter where they are. They tried to give me the scissors during the ribbon-cutting ceremony, and I was proud to be there with a locally elected Hmong official, but I had to tell them, you think they're gonna let a brown man like me with something that big and sharp on the plane? Nah, I couldn't take it home, so I left it there, but I did leave with a lot of powerful memories about culture as health here in California. A second example I'd like to share is the Sweet Potato Project, where you had Black farmers taking land and taking youth, using the zip code approach, using the census block and tract approach for areas with the highest, worst impacts of health for teens. Teen pregnancy, substance use, violence, and taking those youth and asking, what would be a project that you would enjoy? What they did was they plant the sweet potatoes in the spring. They tend to them with their families in the summer, and they harvest them in the fall, and then they take business classes at a local university to learn about entrepreneurship and empowerment and sell sweet potato muffins and shakes and have food trucks and learn the skills. And we've seen positive mental health outcomes and physical health outcomes thanks to these early culture-based interventions. So, let's get to the heart of it. It's all about trust. In the Eisenhower era, public trust was at 75%, and now it's at 25%. Trust in government and even in the sciences is at an all-time low, so we have to hit it head on, and we also have to name and acknowledge trauma. Pew tells us, as of recent literature, that there is a growing mistrust in science, medicine, and public health, and it's having an impact on childhood vaccination rates. We see measles not only in Europe, but even showing up here in Los Angeles. And with reproductive health, crisis pregnancy centers across California, denying people access to all the information that they need to make the best choices for their bodies. Yes, misinformation is geopolitical. It's a threat. We saw it during the pandemic. We saw it during elections. And in a major election year, we need to be ready for it. We need to play defense and we need to play offense. So what I'm talking about is truth decay. Not tooth decay. That's an oral health issue. I'm talking about truth decay, which is a moral health issue. We have to engage in rebuilding the public's trust due to the centuries of harm that we've caused and the trust that we've lost, even in modern times. And it's an uphill battle. So I was basically on ground zero when the cruise ships were coming in with coronavirus into the Bay Area, the Diamond Princess, if you remember those days. And if you see the date on this press conference I spoke at, it was March 10th, 2020. My boss was out of the state, so I had to go to this press conference, and we implemented the first in the nation stay-at-home orders because of the spread of the virus. And so I quickly learned that earning the trust of people is so important, even in a time of uncertainty. Now, when I was appointed to serve at the state level and support vaccine equity efforts here in California, some people were very supportive, like Richard. He said, "Oh, my wife was Dr. Rohan's patient for many years. He's great." And other people like Elizabeth, who didn't know me, said, "When will a doctor with a name like Sam Jones be appointed to head such an agency? Why is it always someone with an unpronounceable name and a foreigner?" Well, Elizabeth, I'm not a foreigner. I was born in the cornfields of Illinois, and I grew up in the wheat fields of Kansas. And by the way, why not appoint someone with a name like Samantha Jones? There's so many biases that people hold, and it is our duty to work from an intersectional lens and reach out to folks like Elizabeth, especially during an election year, to form bridges through the universal values of compassion and dignity, to work together to get the policies that help everyone. So trust really matters. And at the height of the pandemic, before therapeutics came on board, when we didn't even know which masks we should be wearing, we went to learn and support the community. We knew that faith and culture was so important, and distancing was for ventilation as well. So here you can see an outdoor sermon, and we co-wrote the sermon, Padre Lázaro Sandoval, 2 blocks from the clinic that I worked at as a local health officer. And I brought along first-generation medical student in college grad Sofia Gonzalez, one of our interns from the family medicine residency program, and my daughter, who was just about 5 years old at the time, to do some public education around hand washing and covering your cough. You know, it was a powerful moment when we went to home base, literally the home base on a baseball field, to have an outdoor sermon and talk about public health prevention. And, you know, my daughter says I get one dad joke in every talk that I give, so brace yourself. Here it goes. What do you call someone who tells a dad joke but isn't actually a father? Someone who tells a dad joke but isn't actually a father. That's what you call a faux pas. So, trust, culture, it matters. And at the state level, at the height of the pandemic, we used data. Here in Los Angeles, we partnered with Lalo Alcaraz, a cultural creator of Coco. If you've seen the movie from Pixar on Netflix, check it out. He has a great daily syndicated column, La Cucaracha, political cartoons. And we partnered with him to do an 8-story mural here in Los Angeles, where in a zip code, actually a census tract, that had low vaccination rates and high COVID case rates to drive traffic to therapeutics. And this is engaging culture as health, porque la salud es parte de su cultura. And we used cultural ambassadors and messengers. We set up a Spanish WhatsApp scanning for misinformation using artificial intelligence, and it got global coverage on CNN and Espanol. So engaging the arts and thinking broadly about our partnerships is so important. So, trust is what it's all about. And this study from The Lancet really showed that when they looked at 177 countries, it wasn't health system readiness or IT systems or workforce. It was trust in each other and trust in government that was the highest association with vaccination rates and low mortality. Now, we got to talk about trauma, too. Trauma amongst the communities that we're serving and amongst ourselves. The idea that we can be immersed in suffering and loss and not be harmed is as unrealistic as expecting to walk through water without getting wet. And we know this hits home for many of you who have been doing direct service work during the pandemic. We gotta go beyond burnout and acknowledge that our mental health is suffering as healthcare professionals. Almost a quarter of public health agency employees report at least 3 symptoms of post-traumatic stress disorder. 41% have felt bullied, threatened, and harassed, and I've had plenty of colleagues who needed 24/7 security detail. Why? For speaking science during a highly polarized political moment. So we have to invest in the well-being of our students, of our health learners, of our faculty, and of our staff. And there's a few skills that we can use. There's the 6 R's, which you can see on the left, and I'll focus on the 5 N's on the right, because in every interaction, and I practice this with my kids and my partner and my patients and my staff, every opportunity is a moment to notice potential activation, to name it in order to tame it and have the courage to do so, to normalize and acknowledge that trauma is universal and we're not alone, to navigate it and to be in action rather than reaction with choice and regulation, and ultimately nurture each other through compassion. So we need to ask different questions. It's not 15 minutes with the patient. What's your chief complaint? What's the matter with you? It's what matters most to you. And when we ask different questions, we get different answers. We did that in my clinic, my federally qualified health center, in Vietnamese, Spanish, and English, our top 3 languages. And people didn't say heart disease and asthma. They said food, housing, jobs, health insurance, paying our bills. And so we listened to them. We implemented a food as medicine program and did a validated food security screening, and if positive, we enrolled them in supplemental nutrition, gave them food bank information, and brought food on site, and you'll hear more during Carrie's talk on lightning round number 2. We partnered with UCs and got local students, even from community colleges, to be advocates with health leads, and 50% of patients screened positive. In a year, we handed out 15,000 resource connections, and here you can see the mobile farmers market on site with 2-to-1 matched free organic produce. And yet that wasn't enough, because behind this mobile farmers market is the dollar store, where my diabetic patients will buy cheap carbs. So it's an uphill battle, but we gotta fight it together. So if we wanna achieve the Sustainable Development Goals, and we care about number 3 globally, which is good health and well-being, it's actually about all the other ones. I feel like I'm in my place when I'm the only health person in the room, working cross-sector, because the most important number up here is number 17, and that's the partnerships between community, academia, government, philanthropy, and all the sectors to drive health. So let's talk about some global health trends. And let's start with the climate, because the temperature is rising, and it's getting hot and heated. There are so many of these issues. I wish I had an hour to talk about every one. Let's just talk about extreme weather that 75% of Americans in the past 5 years that have been impacted with, and it's affected their health and their mental health. My team added the pink circle to this Center for Disease Control diagram to talk about the mental health impacts, like PTSD and anxiety, because it is real, especially amongst our youth. The migration of new vectors, mosquitoes, Zika, dengue, chikungunya in the United States, West Nile virus. Let's look at coccidiomycosis, fungal spores. It's no longer going to be called valley fever because it's spreading out of the valley to the coastal areas. It's hard to distinguish from a pneumonia. And extreme heat, the top killer. You'll hear more about that because the temperature is rising. And so globally, finally, in Dubai at the Conference of Parties last year, we had a declaration on climate and health, and it's no surprise that 2 years ago, 200 medical and public health journals wrote a joint editorial that this is the greatest health crisis and issue of our lives and century. So we need the health system to stand up. We are part of the problem. 8 to 12% of global greenhouse gases coming from the United States are from our pipeline and supply chain in the healthcare sector. We need to decarbonize ourselves, but also be spokespeople, not just for mitigation, but also adaptation and resiliency. Yes, talk to your doctor about it. Climate change is affecting their health. But we can take and learn from tribal ecological knowledge and from the global context other ways of being, like my spiritual teacher, Thich Nhat Hanh, shares. It's about interbeing. It's about the interconnectedness that the Chancellor mentioned earlier this morning. And the One Health framework is a powerful way to look at that. No matter what country you're listening from today, there are globally One Health communities that you can be a part of. And we just hired a veterinarian in our Department of Public Health to be our One Health lead in California. So connect with her if you're interested in more One Health work. The temperature is rising, and during a heat wave when I was a local health officer in Contra Costa County, NPR interviewed me back in 2020, and they said, as a health expert, what can you tell people who are drinking hot tea and eating spicy food during a hot heat wave? And I had to tell the reporter, look, we're at the center of an unfortunate Venn diagram with multiple overlapping emergencies. We have structural racism, social inequity, climate change, poor air quality, and a virus. This was that week when people didn't know whether to open or close their windows because it was hot and you wanted to open it and have ventilation from a virus, but there was wildfire smoke and so you wanted to close it. Because I changed the narrative in the conversation, the reporter ended up doing a story about redlining and pediatric asthma hospitalizations in some neighborhoods more than others. So we have to change the narrative and not let people tell us what are the topics that matter. The temperature is rising. And 2 years later, we had a record-breaking heat wave across California where our team just released a report. Almost 400 Californians died. And by the year 2050, we will have 11,000 excess deaths a year. Many parts of the globe are facing this, and our data showed there's certain communities that are hit first and worst, like with COVID. Working-aged adults. It wasn't actually the young and the elderly. It was people aged 25 to 64, Latinos, and those in the unacclimatized coast who disproportionately died. The temperature is rising. And so we have to acknowledge that racism, not race, is a major risk factor for the spread of disease, and that racial injustice and climate injustice are both rooted in the evil notion that some lives are more important than others. I can't breathe were the last words from George Floyd. I can't breathe reminds us of our patients with COVID who needed to be intubated, ventilated, and lie prone. I can't breathe is what communities experiencing environmental injustice are screaming with air pollution, one of the top 10 global killers relating to all health conditions. And so I want to invite up someone to tell us a little bit more about how the temperature is rising. Please welcome up my brother Jacob, a community leader and a spoken word activist.
Good afternoon. Good afternoon. Good afternoon. How's everybody doing today? Oh, I don't believe it. I don't believe it. If y'all are excited to be here, can I get a woo woo? If y'all are excited to be at Global Health Day, can I get a woo woo? Amen. Amen. Well, first I want to give a huge shout out to my boy Rohan. His introduction was so beautiful and so lovely, and to be able to see all of you all has been such a lovely experience. Today I'm going to be talking about, as Rohan mentioned, the temperature that's rising. Today is Global Health Day. We're talking about all of the different things that's going on in our society. And this piece that I have is called The Temperature is Rising, because I want to talk about not only the societal climate change, but also physical climate change that we're experiencing. So without any further ado. The temperatures are rising. Yes, things are heating up. Our societies and ecosystems both need a tender touch. Our resources are dying. Our seas are overflowing. Well, it's a lack of unified vision that's keeping us from growing. A lack of proper education is keeping us from knowing that we must find change soon before this earth goes up in smoke. Greenhouse gases daily getting more potent. Systems are strategically corrupted so our spirits will be broken. Soot-covered hands slave in factories for tokens, shooting toxins into the air we breathe while ripping our ozone open. Things are heating up. That cold truth has been unfrozen. melting just like glaciers fading slowly in the ocean. And as filthy, vile, and disgusting lies rise to the surface like the lifeless fish that the ocean spits up, you can still hear the whispers of children through moonlit skies, wishing on shooting stars for a brighter tomorrow. A tomorrow that isn't filled with unnecessary pain and sorrow. A tomorrow where love is supreme leader and everyone follows. A tomorrow where there's storehouses of hope for your neighbor's neighbor to borrow. A tomorrow that isn't drowning in the decisions of yesterday. The temperature is rising. It's getting hotter by the day. It is through our faith we build resilience, and through that we pave the way. The temperatures are rising. 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 Thank you.
Give it up. With Jay with the tray, there you go. All his info up there. Thank you so much, Jacob, for bringing the love. We appreciate it. Jacob brought it, and now how are you all going to bring it? As health professionals, we must motivate climate action because for the first time ever, beyond jobs, health is the #1 reason why Americans want climate solutions. And who do they trust? You can see on the right, it's not Congress people right next to car sales people. It's nurses and doctors and pharmacists and teachers. It's you all. It is the health professional class that needs to get in the game of decarbonizing and being our spokespeople and leaders for planetary health, for population health, and for people's health. So you're going to hear a lot more about that in our first panel this afternoon, talking about environmental justice. And you're going to also hear about reproductive health, something that California is really stepping into. We have our second Surgeon General ever, OBGYN, Dr. Diana Ramos, who's working on it, our governor, who's a leader in the reproductive health space, and our office, who has also really worked to promote by launching the website, Abortion Finder. So no matter where you're coming from to California, you can get the life-saving services that you need for your family and have the information to know what's best for your body. A couple of the themes I need to briefly talk about include artificial intelligence and global health. There are promises, and there are also perils. We need to talk about how it can help virtual health assistants and population health, but also the impacts on privacy and ethics, and the equity implications of all the isms. We need to also be ready to talk about the benefits, and we see this in the global environment. Let me give you 4 brief examples. We have machine learning and signal processing methods to help us with diagnosing multi-drug-resistant tuberculosis. We have from Thailand using these algorithms to help predict risk for dengue fever severity. We have predictive models helping us understand Zika transmission globally. And in South Africa, talking about workforce to understand who's staying in the communities. So there's a lot of topics, but we want to end by really talking about what you all can do, which is really what matters most. So let's start by getting humble. As global health learners and leaders, I'm grateful for the work of Melanie Turvalon and Jean-Marie Garcia. We have to start with our lifelong commitment to critical self-reflection and acknowledging our own powers, privileges, prejudices, biases, and blind spots. And we need to work towards redressing those power imbalances and promote institutional accountability. And we'll talk about that no matter what part of an institution you belong to. When I took my oath of office, my boss reminded me that it's about humility, which is the noble choice to forego our status, to use our influence for the good of others, and to hold our power in service of others. And we're going to talk about power here. So we need to acknowledge and reflect have language that's inclusive, include narrative and storytelling like Jacob just did, have an intersectional approach, and have diverse messengers and diverse platforms to reach people and rebuild trust and truth. We surveyed you all, and you told us these were some of the skills and the tools that really mattered in the buckets of emotional intelligence, thinking, engagement, leveraging technology, systems thinking, and you're going to hear more about data disaggregation from Alec in a lightning round presentation. And inclusive leadership is so important to build a broad tent and form coalitions with space for everyone. There are so many free resources to learn these skills and tools, including at the UCs. You have the Global Health Institute with their One Health Workforce Academy, just one of the dozens of topics we're covering today. And so I invite you to be part of the system that has caused harm, to help change it for justice and for health and well-being. Come on in, Trojan horse style, and help us transform government. At the Department of Public Health, we are hiring about 1,000 people, and certainly we're welcoming interns for opportunities. And so you can see our fall cohort if you'd like to apply and come be a part of the solution within California state government. I think I see some budding bureaucratists and some emerging advocates in the room, so we got plenty of space for you. Come join us. And at the end, when you look at this Ikigai graphic, you'll find as you shift towards your life and your career, knowing what the world needs, pairing it with what you love and what you're great at, and ultimately what you're paid for. And this will shift over time, but continue to look in the mirror, be quiet in nature to figure out where your place is. We're going to end by talking about moving from science to action. And I got to start with gratitude towards Dr. Monica Sharma, the former director of United Nations Leadership Development, that really reminds us to lead with these universal human values. Banksy says, keep your coins. We want change. Personal change, workforce change, institutional and policy systems, and environment change. And so there's even things for racial equity that you can do by next Monday at the structural, institutional, interpersonal, and internalized levels. There's things within your major or your department or your healthcare center or your academic institution that you can do by joining committees for diversity, equity, and inclusion to drive our institutions from being exclusionary or compliance to more affirming and more transformative. What would it take to move from a 3 to a 4? The spectrum of community engagement is something that we all can use to continue to advance. And I struggle and ask our government programs to look in the mirror and say, what are we? Are we a 2 with our community healthcare workforce initiative? And how do we become a 4? That's what community's asking for. And what's happening in the global context, and what can we learn from that? So if you're doing research with one of your posters in the back, or if you're starting a new collaboration as a faculty member working globally or locally, how can we put more resources and more decision-making power? Who gets to ask the research questions and design them? And what is community's voice at the table? So I ask you to use the spectrum and have your community partners rate you on where you are and where they'd like you to be. One frame and skill that's really important, and I am grateful to UC Riverside for bringing this from their Center for Social Innovation, is the DNA framework: data, narrative, and action. And so I tell my epidemiologists that we can't just catalog the carnage of disparities. We have to pair it with narrative in the same sentence to change hearts and minds, and we need to include constructive solutions for action every time, or we're not doing our full duty and job. So let's talk about narrative for a moment. I invite all of you to look at the screen, and soon we're going to unveil behind the golden curtain what we see. And on the count of 3, I want you all to shout out with me what you see. 1, 2, 3. Oh. We all have different frames. We fill the gaps in our minds and in our brains and have half the resources and information to process and use a lot of preconceived notions. So as we're building bridges with people with different backgrounds and different frames, centering on those universal values, being a student of narrative is so important. So I'll end by talking about how we can use policy and advocacy to impact change. The theme and the title for our Global Health Day, the 10th today. So this comes from the Federal Health and Human Services Agency, and it's a framework that's been used in philanthropy for many years, and I'm so glad it's gotten traction with Secretary Becerra and others, and Admiral Levine, Associate Secretary for Health at the federal level. It's the 7 vital conditions framework, and really takes that upstream approach. And at the heart of it, which matters in this election policy year, is belonging and civic muscle. Civic agency, collective efficacy, equitable access to information, vibrant arts, culture and spiritual life, and social support for civil and human rights. So let's look inward for a moment as the UCs. What power do we have within our systems? What policy changes have students pushed for and made a difference globally? How may we have contributed to harm? Let's not be afraid to ask the questions for transparency and accountability of what's in our portfolios, our endowments, our pension systems. And so back during apartheid South Africa, the UC divested. When I was a grad student at Berkeley, I should have been studying the kidney. Renal physiology's always tripped me up, but instead, I was here at a UC Regents meeting working on divestment from the genocide happening in Darfur because the UC was funding, indirectly, multinational companies that were supporting the regime. And we succeeded. After months of work, after working with departments of public policy, not just the health sciences, it made a difference. And then divesting from the fossil fuel industry in 2020, we have power and voice. So I ask you all today, what is within our power as students? What are the issues you care about as researchers and institutions? How may we be contributing to harm? We've divested from tobacco. What about other issues that harm? The arms industry, the prison military industrial complex, looking at what's happening globally. How can you use your power for advocacy and influence? Whether we like it or not, health is political and civic engagement is tied to community health. So what is the role of healthcare professionals in civic engagement, if at all? Oh, it's big, and Rudy Virchow used to go to protests back in the mid-1800s, the father of pathology and social medicine. We've had nurses and healthcare professionals, women, men, people of all backgrounds from the 1800s and before, speaking truth for policy change, from the Flint water crisis to the COVID-19 pandemic to Myanmar. And so, I hope some people in the room will be our future boards of supervisors, our future city, county officials, our future state and global and federal officials, whether elected or appointed. Because there's a lot of lawyers in politics. We need more health and education people at the table to drive policy. So, what year are we in, 2024, the 10th Global Health Day of UCGHI? It is a big, perhaps the ultimate, perhaps the election year. In the United States, we have pretty low voter turnout, and even the Center for Disease Control with their Healthy People's 2030 initiative set a higher target. Back in 2018, it was only 53% of those reporting that they had voted, 18 and above, who are citizens in local, state, or federal elections. And so the goal is 58%. And we know that's much lower than what's actually reported and in other countries. So we got a lot to learn from the global context about trust and agency. But it's not just here in the United States where we have a big presidential election. It's more than 50% of the globe's population in over 64 countries where voting is happening and where suppression and violence can threaten the vote of the people. So let's end with talking about how do we make change. It's really about power. I used to be a student of the kidney and of the endocrine system, and now I'm a student of narrative and of power. We have to, with respect, engage in disruptive power. We have to learn from our partners in the arts and communications about narrative power. We have to engage in political power and economic power, modeling power, and healing power if we want to undo that multi-century monopoly game that's taken place. So I end with this beautiful image, the People's Choice Award for Photography of the Year that just came out in The Atlantic a couple weeks ago. That's called Starling Murmuration. And how beautiful and powerful when we flock together. Adrienne Marie Brown reminds us that there is an art, not just a science, but an art to flocking. Staying separate enough not to crowd each other out, aligned enough to maintain a shared direction, and cohesive enough to always move towards each other with humility, with love, with interconnectedness. So I ask you, in the spirit of leveraging your skills and power and connections, to move upstream It's not the social and structural, but the political determinants of health. To engage and spend your brain, your heart, your time, your budget more on advocacy and policy. And I ask you all, change agents, to unite. Thank you.
Thank you so much, Rohan. This is the time where we get to ask Rohan questions. So as a reminder, there's a mic over there and a roving mic as well. But while I have the floor, I have so many things I want to ask you about, but I was struck specifically by a comment you made where you said you feel most successful when you're the one health-focused person in the room. So maybe you could share a little with all of us on sort of what work you did to create spaces where you could be that person or gain the trust to be the voice of that person.
Absolutely. You know, for a moment, Jacob, who shared poetry with us today, you should know that he's a youth organizer in Oakland for the general plan. Raise your hand if you know what a general plan is. 2 people. The general plan is what determines the built environment and the social, structural, environmental determinants of health. Where can factories be built? Where can bike lanes be built? Where are there food and liquor stores? So no matter what the issue is you care about, working with planners and architects really makes a difference over decades to change the conditions for health and where resources are. So when I was at the local level, there were plenty of health people interested in communicable disease, tuberculosis, but I carved out a niche that was more in those social factors, environmental, going to the general plan meetings, working with community organizers like Jacob, getting community and health voices to the table where the decisions matter that determine health access for decades. And then at the state level, perhaps my favorite part of all the roles I play is on something called the Strategic Growth Council, which is actually 6 different secretaries that focus on sustainable, thriving communities. So that's housing and transportation and natural resources. So being the health voice in the room is something that is really about translation and being able to work across divides to try and slip in health into no matter what the policy issue is people care about.
Thank you. Feel free to shout out if I don't see you with the light. While we're waiting, if there's any other questions. One of the pieces that you talked about related to climate and climate health and climate impact, I was surprised, I don't know why I was surprised, that there was still so much trust in folks interested in health. But we're behind a little on our own training on how to even ask questions about the health impacts. What do you think are the first steps to bringing all of us who are interested in health or health professionals to the table with the right skill sets to address those questions?
Yeah, well, it needs to start in middle school to get it into the curriculum so people know both the realities and the crisis that we're facing, but also have hope. And that's the power of bringing youth and empowering youth, which is so important, but it needs to be part of our curriculum. It needs to be on board exams. We need to understand the impact of all the climate stressors on how it affects physiology in complex ways, and it needs to be part of training from pre-med through postgraduate education. And there's so many societies, medical societies, Consortium for Climate and Health at various universities across the globe. Within the UCs, you have the new Center for Climate Change and Health Equity that we've partnered with closely. And you need to learn diverse skill sets. So if you're gonna take a class, don't take a class on COVID, take a class on communications or climate or a cross-cutting theme where you can learn skills that you can really translate for whatever issue it is that you care about. But the climate one is so cross-cutting that we all need to find our touch point with whatever issue is that we care about.
That's great. One of the other pieces you touched on was around training around cultural humility, which is a topic that's dear to me as well. And one of the tenets that I think of often and most is reframing the concept of expertise. You touched on it by saying, let's remember the expertise of our community partners. How have you used that language and how have you reframed really understanding both lived experience and professional experience as expertise in environments that are very maybe academic or political, where expertise in a specific way is held very high. Does that make sense as a question?
Yeah. Well, look where we are and what the data shows. So clearly the experts have been wrong.
Yeah.
We need to listen to and talk to new people and form new partners. So even if you just take the 15-minute clinical encounter and how we walk in with so much ego and interrupt patients in the first 8 seconds, rather than hearing their story, which really tells us about what's going on in their lives, it's different. We can do a chart biopsy and think we know what's happening, or we can ask people what matters most to you. So along all stages, I think, changing, flipping the classroom, getting people out to community, paying people for their time. And we're trying to do that in government by, for every community, having lived experience advisory boards and bring those people into government, change the rules, ban the box, remove certain ceiling requirements for educational requirements for people to take positions because people have a lot of experience from being from those communities. And it goes back to research methodology. You know, before you do the quantitative, you got to start with the qualitative and ask 10 questions before you land on one question, and they got to be open-ended. So you really, with humility, start with you don't know, and you're there to learn.
That's great. Oh, there's a question.
George Rutherford from the University of California, San Francisco, and a former state health officer, I should add. You didn't really touch very much on commercial determinants of health, or if you did, it was before I managed to find out where Ackerman Student Union was. And you know, we have this long history of sin taxes, going back to the 17th century with the penny a glass tax on gin in Great Britain, up to and including the peso per liter tax on sugar-sweetened beverages in Mexico. It always seemed to me that that was kind of a almost low-hanging fruit, that it was always easier to be against something than for something. How does that figure into your universe of thinking about ways to intervene?
Wow, thank you, George. So give it a hand for our former state health officer, George Rutherford. George, you may not remember, but during the pandemic, we spoke on panels about getting people outdoors and into the parks, more good ventilation, back to the sanatorium days. You don't have to shelter in place. You can be out and about, and we really talked about the importance of connectedness during the pandemic. So thanks for your service before and now. I took that slide out because I didn't have space to talk about the commercial determinants of health, so thanks for bringing it up. And if you haven't read the book about the corporate hijacking of the American mind by UCSF endocrinologist Stuart Lustig, check it out. It's pretty depressing. And that's why I said in that photo with that UC Berkeley student connecting patients to food, behind that farmer's market truck was the dollar store. Those are the commercial determinants of health. How are we subsidizing high fructose corn syrup at the government level, or petroleum, or sweetened and sugared beverages? And so I did leave it out of the talk. Thanks for bringing it back in, because it's a whole nother world that is so powerful. The marketing influences. How do we learn from how corporations market unhealthy things via social media or otherwise to the masses? And how do we take some of those skills and learn them in undergraduate and in graduate school? So it's a really important thing that you brought up. It's overwhelming, frankly, the budget mismatch between what health and government can put up compared to corporations for marketing of products that are harmful to people's health. And we're really facing that battle with social media right now, particularly with youth mental health. So thank you. We absolutely need to move into the commercial determinants of health space, but I think you could find a place on the diagram of the political determinants of health that cover it. Thanks.
I know that we're probably going to say this about 50 times today, but where there's not enough time. We have to end, but I just wanted to say that we were really excited when you said that you were going to be able to come and start us off today, not just because of all the amazing work you do, but because of your frame of approaching things, as you said, with love and just thinking about ourselves as a community. So I hope all of you are walking out of this space feeling even more tightly part of a community with also a very specific call to action. And so thank you so much to Jacob. And thank you, Rohan, for bringing Jacob. And thank you to you as well, Rohan.
Change Agents Unite.
I'll pop this back up for you. Okay, I'm calling Sun back up here.